Everyone's here for EpiBio, correct? I hope so. I think I read the schedule correctly. Okay. This is going to be a hybrid class that we will. The syllabus should be uploaded. You should have access to that to see the PDF of it. The schedule I also uploaded as well. This is primarily going to be an online course, so I'm sure Friday everyone's going to be diligently watching roughly 6 hours of biostats videos that I will have uploaded by then, right? Sure. Okay. So anyways, I'll certainly be working on that most of this afternoon, getting those videos ready for you guys to review. But this is the intro, and then we're going to have a couple of in-class sessions. I'm going to try to make those primarily kind of a journal club, right? So I guess just to start off with, I kind of want to talk about what the point of this class is. So is anyone like an epidemiology or a biostats like expert or have any pretty well versed in it before coming here? Okay, right. So everyone should be kind of coming in on the same page. I came into pharmacy school really knowing nothing about looking at the literature. And so why do you think this is important to know at least the basics of epi and biostats? Evidence-based practice. And what is that?
Basically, carrying out treatments that are supported by evidence and research.
Absolutely right. So people do the research, people do these studies, and it's important that we be able to look at those studies, look at that evidence to see like, well, is it bogus? Like, does this actually make sense? Does the evidence support what my practice is? So that way, when you're treating your patients, you can say that this is most likely going to be the best thing for you, right? When you say, hey, you know, we need to do this surgery on you, what are your chances of having complications? What are your chances of having a successful recovery? Things like that. And this is what the evidence can tell us. And so it's really, really important to at least have the background to be able to look at a piece of literature to say, like, is this make sense? Is this a good study? Are there techniques rigorous, and is it generalizable back to my patient that I'm dealing with, right? And so we'll see that a lot of this is about evaluating data being performed or being collected from a large number of people and trying to apply it back to your individual patient, okay? And so does anyone think this is going to be like a very exciting or sexy topic? It's not. It's really not. I hate to tell you right now, it's not. But I'm going to try to make it at least show you why it is applicable to your practice, why you should actually care about this stuff, because it is super important. Because you don't want to be someone who goes and practices and says, "Hey, we're going to do this therapy," and they're going to say, "Well, why are you doing that?" And you go, "I don't know. Someone else told me to do it." You don't want to be that person. You want to be the person to say, "Well, I have these studies to back me up, and this is why I feel that this is the best course of action." Okay, so this is kind of the background of why we are covering this and why this is going to be important to you in your day-to-day practice. The journal clubs are essentially going to be our opportunities to actually look at real pieces of literature in the medical literature. I'm going to try to take recent articles that we can look at and evaluate so that we can apply the stuff that we're learning here, kind of the pieces, and apply it back to an actual piece of research that has been done in the medical. So I'll try to pick things that are pretty recent, try to pick things that are applicable to what you guys are covering in your courses. I think we'll have 2 or 3 sessions. The first one is basically I'm going to give you guys an article. You're going to look at it, evaluate it. I'm going to have a list of questions that you guys can kind of go through and start to kind of look at beforehand. We'll all meet up in class, and then we'll kind of go through each of those questions, and we'll discuss it back and forth to see like, hey, is this a good article? Does this make sense? Did they use kind of rigorous tests, and is it appropriate what they did for their their conclusions? Is what they the research they did, does it support their conclusions? That's one of the big things you're going to evaluate. And then we'll also do kind of another session where it's going to be, I will assign everyone into groups, and then we'll hand out random articles, and then you guys will have basically 20 to 30 minutes or so to go and go try to evaluate it very quickly. We'll come back, and then we'll have a little kind of group presentations where we can talk about the articles and kind of see what your critical thinking skills are in evaluating some of that literature. So I think people find the sessions pretty fun, fun in a relative term. And that at least it is good to be able to apply that information back to what you've been learning in these kind of more dry lectures. So, okay. In addition to that, there's also going to be 2 tests. I can't remember the percentages right now, but the participation grade for participating with the journal clubs is a big part of your grade. And we'll have 1 test that is concerned with the biostats, which is what the first section of this class is going to be on. And then the second one is going to be on the epidemiology section of this. So again, the tests are kind of segregated based on topics. Okay. So again, the objectives for this lecture, at least, are going to try to delineate some of the reasons that we use statistics and why probability, and they're not really intuitive. You'll find that a lot of these things we're looking at are kind of abstract in nature, and we're going to try to see how we can apply these in a concrete fashion. We're going to look at some of these obstacles of why statistics are so hard, and then try to understand some of the terms and the applications of statistics, and see what we can look at in evaluating probabilities of a sample and how we apply that back to a population, right? Because when we do studies, what do you think are kind of the typical sizes of people that we're looking at when we do some of this research, some of this literature?
You would hope they were large.
You hope they're large, right? Why do you hope that? More diverse, okay. Maybe you can find statistical significance. We're going to talk about that term quite a bit and what that means. You want it to be representative of what the whole population that you're caring about is, right? And we'll talk about that. We'll say, like, if you're looking at hypertensive patients, you want whatever group of people you're looking at to be representative of that entire population. So that's going to be an important point we're going to look at. And one of the big things you're looking at when you're evaluating the literature is, like, what type of patients were they looking at? Is this applicable to my patient that I'm dealing with? If you're looking at a study that was only dealing with 80-year-old African-American women, is that appropriate for applying it back to your 30-year-old Caucasian male patient? Sometimes yes, sometimes no, and so it's important to be able to kind of differentiate that and to evaluate those sort of things. Okay. And again, with statistics, 60% of the time it works every time. You're going to find that we're going to throw a lot of numbers around here, and it may seem like we're just kind of making up stuff on the spot. I guarantee you there's a method to the madness. I'm not going to have you actually calculate a lot of these things we're going to talk about, like standard deviations, and I'm sure everyone could do an average, right? If you had a calculator, you could figure out what the average of something is, but I'm not going to have you do standard deviations or necessarily number need to treat, things like that, but we will at least look into what goes into those numbers and why those are important. We tend to jump to conclusions very often, right, based on things like anecdotal evidence is given to us. And when we have data that contradicts kind of our conclusions, we tend to question the accuracy of that new data rather than looking at the validity of our kind of prior conclusions, right? It's really tough to kind of go back and say, like, hey, I was actually wrong. The thing I thought before was wrong. I need to go back and kind of re-update my thinking. And so this is actually very appropriate. This is me and my wife's 4-year anniversary. We are still together. Our baby has got a bunch of shots yesterday, so it was kind of putting a strain on the relationship last night because she was very, very cranky, but that's okay. But anyways, I would like to show you a real life case of how I use statistics to my benefit. And so back when me and my wife were engaged, we needed to move to Orlando for jobs, and she said, well, we can't move in together because that's going to increase our risk for divorce. And I said, well, what's your evidence for that? What's your reference for why you think this is going to increase your divorce? She said, well, I read it in Cosmo. How rigorous do you think the studies are done in Cosmo? Very. Okay, so yeah. I would challenge that. So I said, I don't think so. So I decided to look at the research. And so I found a nice article from the CDC. So if I had to believe one source of information, CDC versus Cosmo, I prefer CDC, right? So I decided to look at marriage and cohabitation in the United States. This is a study done back in 2002. So I said, well, what the heck is the evidence? Does this really increase our risk for divorce if we decide to cohabitate beforehand? Live in sin, as it were. So anyway, so what we found was, or at least what I found in this article, was that previous cohabitation, the experience was that they significantly associated, and we'll look what that term significantly means as we get more into details here, but it was significantly associated with marriage survival probabilities for men. In general, men who cohabitated prior to their first marriage had lower probabilities of that marriage surviving to the 10th anniversary than those who did not cohabitate prior to their first marriage. So, well, that's not good. That seems like that is correct. Cosmo, I actually have something to it. I said, however, though, those men, I apologize, this is kind of highlighting here, but those men who were engaged at the time of cohabitation with their soon-to-be first wife had similar probabilities as those that were married before cohabitating. So about 71% for men who were engaged in cohabitation, 69% who had never cohabitated beforehand. So do you think those numbers are significantly different from one another? 61 or 69 versus 71? Not really. I said those are pretty similar. I said, well, we're engaged. So we probably should have similar 10-year risk, which obviously having a 30% of those people already dropping out, getting divorces is kind of a disheartening number to begin with. But I was able to take this evidence back, and guess what? We moved in together. She acquiesced. She said, well, I guess I'll throw out this Cosmo knowledge and kind of reevaluate this. So good thing we were engaged. This way we won't have to pay for, really I was doing it for a money sense just because I wanted to pay one rent instead of us paying for two, but that's I didn't tell her that. So again, we're at the 4-year mark. We're still together. We got another 6 to go, so we'll see if we actually make it that far. I plan on it, but we'll see. Okay. So anyway, so we tend to jump to conclusions in a lot of cases. So we're kind of hardwired to generalize information from a sample. So if you see something, several times within a given sample, you tend to generalize that back to a population. So a lot of cliches come up. There's how a lot of stereotypes come about. And so you really need to make sure that we're looking at the statistical rigor of these things to make sure we don't make kind of overly strong conclusions from the limited data that we have. And one of the things you'll kind of notice is once you get more into evaluating the literature is you really never talk in absolutes. You never say, a patient comes up and say, hey, is this procedure going to fix my problem? You say, you're never going to be like, absolutely, this is going to fix it. You say, well, chances are it's very likely that this is going to fix your problem, right? You always kind of leave yourself an out because statistics are never going to be an absolute thing. There's always going to be some degree of uncertainty there, as we'll see when we talk about the numbers of confidence. We're looking at the degree of confidence we have for some of these things. We see patterns in kind of random data. So, for instance, if you're a fan of basketball, some people believe in players having hot hands. Once a player makes a shot, that he or she is more likely to make the next shot. And so, if you were to look at some of the data there, you would see they were looking at, say, from 1980 to 81, they're looking at the Philadelphia 76ers, and they said, well, what does actually the data show? And so you'll see that there was no real correlation there between making a shot and then making subsequent shots there. So, for instance, we'll see this in a slide in just a second. But the table will demonstrate this. We can see how clusters of things kind of lead us to believe an incorrect conclusion there. So, for instance, if you're looking at this table, you're going to see that an X would have been a shot that was made versus a minus sign here would be a miss. And so, if you're looking at this, 10 different players. And so, what do you kind of notice about the information here? Do you think this would support your conclusion that players have hot or cold hands, where making a shot would beget other shots? You might jump to that conclusion, right? Because there are some clusters here. Okay, this person ended up missing a bunch of shots in a row. This person's making several shots in a row here. But if you actually did the statistical rigor of it and you actually went through and performed these tests, you would find there's actually no actual correlation here. There is no statistical significance to making one shot and then getting subsequent shots. But our brains are hardwired to look at patterns, right? That's kind of one of our survival instincts as mammals. This is why we're the dominant species, because we can notice things like, okay, well, the sun's always going to rise in the east and set in the west. Wintertime's going to come and we're not going to have anything to, our plants aren't going to grow. Those are kind of the patterns that helped us do, if you go watch like Planet Earth or something or not Planet Earth, what's the Neil deGrasse Tyson one? Cosmos. If you go watch that, they talk a little bit about how being able to recognize patterns is really important for us as humans. And again, that can lead us to make incorrect conclusions as well, because we're not really good at looking at this data. Again, that table is completely random. Each spot had basically, if you did the test, 50-50 chance of a player either making a shot or not, just like flipping a coin. Really nothing to lead them to make subsequent shots more successful or not. Even if you know that a pattern is completely random, a lot of times it's hard not to see patterns that kind of show up there, because again, our brains are developed there, and that's why we need these statistical tests to make us see that, hey, just because we see a string of patients who end up having one particular type of outcome, that's not going to apply to every single patient we're going to see. Sometimes things clump together. Sometimes you're going to see kind of runs of things that occur. It may not be representative of the whole entire population there. So. Okay, so again, when you're looking at it, we don't realize how common it is that coincidences occur. So again, if you're looking at, what is the chance that a set of coincidences would actually happen in any given period, right? So if you think about it, it's very unlikely that a very particular coincidence would occur. I'm going to talk about an example here. You guys ever heard of the birthday paradox? Talk about that in a second. But basically, it's very unlikely that a particular coincidence would actually occur. So if you think about yourself, like if you think about your birthday, what do you think the chances are of someone having in this room your exact birthday? I think pretty high, pretty low. If you're having I was born on October 24th. The chances of someone else having that exact birthday, anyone born on October 24th, pretty low, right? It's like 1 in 365 essentially, right? So, and we'll look at some of the data there to show that. But the chances of any two people in this room sharing a birthday, how high is that, do you think? It's actually pretty high, yeah. So if you ever look at the birthday paradoxes, we'll see in a second here, it's actually very, very likely that at least two of you will share the same birthday in this room based on just having 65 people in here, right? And so some people are like, that doesn't make sense. Like that doesn't seem very likely. But if you actually look at the real statistical tests, like that is very true there. So again, we think that having these kind of remarkable coincidences, we always kind of note them in hindsight, but what we will notice is that in the literature, like, rare coincidences happen all the time. It's just when you're looking for one very specific one, it's very unlikely to occur in those cases. birthday paradox. So what are our chances that we have two people in this room that have the same birthday? So we have an N of 65. I'm assuming everyone showed up for class today, correct? Let's go with that. And we have 365 days in a year. So the probability that someone was born on a given day is basically 1 in 365, or basically a 0.27% that someone was born on any particular day. So October 24th is my day. That the chances of that occurring is, say, 0.27%. If we look at the probability of someone being born on the same day as me, again, that would just be, again, still 0.27% because it's 1 divided by 365. Now, the probability someone is born on a different day than me is actually very, very good. So I imagine almost all of you are born on a different day than me, correct? That kind of bore out as we just saw. So if you note that, if we're looking at this, 1 divided by 365 is the same as if we did 1 minus 364 divided by 365. So again, this is kind of different ways of showing the same number here, essentially. So if we were actually look at this, the probability of a pair sharing a birthday for a given n, and what is n in this case? Yeah, n is the number of people or the number of observations that we're making. So n is going to be an important variable. It's going to come up again and again, as we'll see. So whenever you're talking about a patient population or a patient sample size in a study, the n is what you're going to be looking at there. So for our n of 65, you can look at this and say, well, the chances of two people in this room sharing the same birthday is 1 minus 364 divided by 365 times 363 divided by 3. So you notice that it's going to become smaller and smaller numbers that we're going to be subtracting from this. And so the actual probability that someone in this room shares a birthday is actually 99.77%. So it's pretty good. So I'm going to have everyone in the room share their birthday, and then raise your hand if you have the same birthday. So say it loud. What's your birthday?
March 23rd.
Anyone else? What about you?
March 12th.
March 12th. Close.
February 10th.
February 10th.
March 27th.
March 27th.
June 18th.
June 18th.
December 9th.
December 9th.
February 16th.
February 16th.
December 16th.
December 16th. Don't prove me wrong.
October 31st.
October 31st. Halloween, baby.
October 31st.
There you go. Boom. And they're even sitting right next to each other. It's not black magic. It's statistics. There we go. Thank you for proving my point so well. That was good. All right. Come Halloween, give them nice gifts. All right. So anyway, so again, we oftentimes will end up having kind of incorrect feelings about probability. So imagine if you had several bowls of jelly beans here. So imagine we have two bowls. You have one small and one large one. So in one of the bowls, we have 9 white and 1 red jelly bean. And then the other bowl, we have 93 white and 7 red jelly beans. So if you had to win a prize for blindly picking 1 red bean, out of which bowl would you pick from? The large one? Why is that? 7%. 7%? What's the chances of picking out the smaller one? 10%, right? So your chances, even though there are more red beans in that larger bowl, the chances are smaller if you're actually picking one out of that bowl, right? So again, you think, hey, there's more red beans, my chances are better there. It's not actually the case. So people, again, oftentimes will make the illogical choice. And thank you for being my sacrificial lamb for this one. I appreciate that. Again, you're not wrong for that. That is human nature. That is what we are hardwired to do. And this is why the being able to evaluate the literature appropriately is so important there. Another example, so again, if you're looking at most people who were looking at cancer risk, and they kind of sampled these people and said, which one was riskier if you described a cancer killing 1,286 people out of 10,000 or 24.14 out of 100 people? Which one do you think would be more risky? Right, so the second one is because it's actually double the risk, and I put it on the slide there. But a lot of people ended up saying that, hey, 1,286, that's a lot of people. That sounds like it's the more risky of the cancers there, right? So again, and especially a lot of lay people intuitively do not make those kind of leaps in logic to make the correct conclusion there. And again, that's why I'm trying to educate you guys so that you're able to make correct conclusions in those cases. Because again, when you look at when you watch any random morning news, they always talk about, hey, this new study found that chocolate helps you lose weight. This one found that going to the gym, it actually kills you. This one found that getting too much caffeine gives you wings, things like that. So they have all kinds of weird studies that are out there, and so people will hear that and say well, this obviously is the case, and they will come to you saying hey, what's up with this? Is this true? And you need to be able to say well, probably not. Here's what the actual research says in those cases. So that's why we kind of educate you on this stuff. Again, we avoid thinking about ambiguous situations. So again, imagine we have jelly beans in 2 different urns. Each one has 100 beans in it. The first has a 50-50 mix of red and black. Okay, and the second one has a mix of red and black, but in an unknown ratio. You can win a prize for picking a red bean. Which urn would you choose? The first one? Okay. Why the first one? You already know it's in there? Or you already know it's 50-50. What do you think your odds are for the second one? It could be way better. It could be 90% chance you could pick the right bean, right? Could be 1% chance. So again, because the stats are ambiguous, oftentimes people go with the safe bet. Oftentimes they don't want to go with the kind of the scarier option in those cases. And so, again, you'd have equal chances if you were to go with the second order. Chances might be better for you, might be worse, but again, and in the end, it's still kind of a 50-50 shot which one you end up pulling out in those cases. Again, almost everyone chooses the first urn. This is a study done back in 1961. And again, nothing's going to tell you in that second urn which is more likely to be in a higher proportion. So again, we just don't know the risk there. But people almost always choose that first urn because you know the risk. It seems like a safer option to you. So again, if you're thinking about that first urn and the probability there, again, the chance of randomly picking from a 50-50 mixture, the second one's definitely more complicated. You just start thinking about ambiguity and probability and all of that. And it's interesting because if you actually were to look at MRIs done of different areas of the brain that get triggered when thinking about these sort of things, you find that ambiguity tends to start to activate those fear centers in the amygdala, right? And you have decreased activity of those reward centers. You guys remember we talked about those just recently, a couple weeks ago? All right, fantastic. All right, yeah. So again, the ambiguity there, just like I don't know, I'm gonna go with the safe option, right? That tends to hit that reward center a little bit more. Okay. So has anyone heard of the Monty Hall problem? Yes. Okay. So the Monty Hall is an old game show, which is not around anymore. But basically, what we have are they would have 3 doors set up, and they would have say 1 car behind. Again, if you have the slides, don't look ahead. This will ruin the surprise here. You have 1 car, and then you have 2 doors that are kind of worthless prizes, right? And so when you choose the first one, they would reveal one of the bum doors, one that didn't have any prize behind it, and they would ask you, do you want to switch or change your pick? Okay. And then the idea was, the question is, should you switch in those cases? Should you stick with the door you picked originally, or should you switch and pick the different door? Which one has the higher probability of having the prize behind it? Okay. So I'm going to need a volunteer with this. You want to volunteer? Fantastic. All right. Which one of these wonderful prizes would you like to pick?
Pick the one in the middle.
The one in the middle. Okay. Hopefully this works. Hopefully I do. Okay. So let's see if that was correct. I don't know. We're not going to. So this one actually, the right one didn't have any kind of prize behind it. Okay. So now the question is, would you like to switch your option? Do you want to switch over to this box here, or do you want to stick with your middle box?
Let's stick with that.
Stick with the middle box? What does everyone else in the room think? Switch? Don't switch.
Yeah, stick with your gut,
Stick with, okay. So you want to stick with it. Final answer. Okay, we're going to stick with it. Let's see what. And the winner is. Fell for the trap. Yeah. Yeah, you might have gotten beat up. He had thumbs up though, so he's in a good mood. This is a dated reference, but don't worry. Okay, so the question is, should you switch? And actually, what you find is if you do switch, you have a higher probability of actually picking the correct prize. Okay, and again, that seems unintuitive based on what we know, because again, you think, hey, it's always a 33% chance I'm going to get that. Correct? Not always the case. So, for instance, we're going to look at this kind of step by step here. If we look at this one, say we pick the first choice, see the diamonds underneath this first cup, and then again, there would be nothing under the middle and the right one here. With the first cup, so say, for instance, this is the one I pick. And I stick with this one, and you say, okay, well, this one doesn't have the diamond in it. Now, do you switch or not? If you switch, in this case, you would end up not getting the prize, right? So that's bad. We don't want that. Say with the second choice, say we pick the middle one. We stick with this one. They would, again, eliminate one of the cups that didn't have any prize underneath it. If you switch, hey, you end up getting the diamond, right? And if you decided to pick this third cup here, and again, they would again eliminate a cup that did not have a prize behind it, and you switch, you'd still end up getting the diamond. So what you find is that by switching, you end up having a 66% chance of getting the correct choice, rather than 33% chance if you end up sticking with what you had. Yes?
Why the contest taking 2?
No. There will be one correct answer. And again, we're not dealing with random. I'm not gonna put like A, B, C, and D, and you have to pick one at random. That would be kind of rude. So I'm gonna actually have discrete answer choices. It's your goal to figure out which one is the diamond, and which ones are not. Okay, so that kind of makes sense. It's kind of a weird thing, but again, intuitively, our brains, and who thought that we should stick with the original one we picked? Okay, who thought we should switch? Who's like, I have no idea. Okay, there's a few, yeah. So again, intuitively, a lot of people end up sticking with what they originally picked when statistically it is more beneficial for us to end up switching in those cases. So again, just kind of showing us how we're really bad at stats as human beings. Okay. Again, we find it hard to combine probabilities. So again, when our the best choice is always going to be to switch. A third of the time, you're going to switch away from the correct answer, but 2/3 of the time, you're going to switch to the correct one. So that's why that one ends up being the correct choice in that option. So again, it's really hard to simultaneously think through 2 or 3 different tracks of reasoning there, and that's why one of the reasons why we always like to go with our safe bet. We say, well, I already picked this one, I'm going to go ahead and stick with this, rather than go with that ambiguity of like, well, I don't know, what if I switch away from it? That could be bad. That could be, it triggers those kind of fear centers. We also, anyone ever heard of Bayesian statistics or calculations? So this becomes really important, especially when you're trying to make a diagnosis for a patient, when you're utilizing different types of tests and things like that. Because in general, when you're evaluating a patient, you're trying to diagnose them. Do you start with tests that are very, very invasive and very specific, or do you start with things that are more general and less invasive? Yeah, we start with more general, start with less invasive, and so these your probabilities of whether or not you think a patient has a disease state or not, it gets influenced by what your prior test results are going to be, and then what the results of future tests are going to be. And this is kind of goes back to these Bayesian calculations. And so, for instance, let's look at something like HIV blood screenings. Okay, so let's say that in the whole U.S. population, let's say that the prevalence is pretty low, right? So prevalence, what do you think that is? Yeah, how many people actually have that? So let's say 0.1% of the population has HIV in this case. And so in this case, we were looking at the antibody test. We know it's accurate, but we know that almost all of our tests are not going to be 100% perfect, right? No lab test is going to have 100% specificity and sensitivity. But in this case, let's say that our antibody test is not quite perfect, has say really good sensitivity. It's 99% sensitive to be able to pick up to see if someone has HIV or not. Okay, so we ask ourselves, what is the chance that we have a true positive versus a false positive, right? Because if you have a false positive come up, that patient's going to be pretty upset, right? They think they have HIV when they actually don't. Okay, so let's look at the numbers there. So say we were looking at 100,000 healthy people that we were going to test. All right, so we're just pulling them at random out of the population. We're going to test 100,000 people, and we know that out of that group, 0.1% or roughly 100 of them will have HIV, right? That we just know that based on the previous data that we have, based on epidemiologic studies we have, that we say, hey, we're going to use this number, and we're going to take that as being true in this case. Okay, the test will end up being positive in 99 of them, or 99%, right? So that sensitivity is able to pick up those 99% of those cases. In the other case, we're going to have 99,900 people who do not have HIV. Okay, makes sense so far. And what we'll see is the test will actually incorrectly return a positive result in 1% of those patients. So that means we're going to end up having 999 false positives on that. That's actually pretty big number, right? That's more than the actual number of people who truly had HIV in that first place. Okay, so if we look at that, we end up having 99 plus 999, so we have 1,098 positive results here. And again, out of that whole value, there only 9% of the results that came back were true positives. Does that sound like a very good test? Not super great, right? So again, when you start off with something that has a really low prevalence and you're dealing with these tests, even if they have really good sensitivities, you can end up having a lot of false positives. And so that can, again, be very problematic. That can be very expensive if you're doing a test on a lot of people who don't need it. It can also be very distressing to them if you thought you had HIV and you found out that really you don't, right? So that can be very tough for a lot of people. And so, and again, if we're looking at that in a test as positive, there's only 9% chance there's HIV truly in that sample. So it's not really a very good test for us. And so we'll see that if by changing what that prevalence is in that population to begin with, we can get much different results. Again, most clinicians assume that when you get a positive test result back, that means that HIV is present, right? So if you had something that came back that said, hey, your patient's chlamydia, would you second guess that? Probably not, right? So if you're looking at a test result and it says, hey, patient's positive for HIV, a lot of people jump to conclusions and say, hey, the HIV is there. Or I see this a lot dealing with like my emergency department patients where a test comes back and says, hey, they're positive for cocaine. They must be doing cocaine. Maybe not. Maybe that's not always the case. Maybe that's not the reason why they're presenting in the ER for whatever it is that they're coming with, chest pain or whatever it happens to be. But again, our brains are not really hardwired to combine what we already know about that low prevalence of HIV in that population with that new knowledge or that test result. And so this is where we can look at things like positive predictive values, negative predictive values, which we'll talk about later on, and incorporate that information about what we know beforehand based on epidemiology and be able to apply the biostats to it in order to come to a correct conclusion there. Okay, so if we did the same test in a different situation, it would yield completely different results based on the prior prevalence. Say, for instance, we have 100,000 people now that are IV drug abusers. That's what IVDA stands for. So what would you imagine the rate of HIV would be in IV drug abusers? probably higher, right? So again, people sharing dirty needles, things like that, they end up having kind of high risk behaviors that will end up netting them an HIV infection in some cases. So let's say, for instance, we're dealing with a group, instead of having 0.1% of that population having HIV, we're going to say 10%. We know that of IV drug abusers are going to have HIV. And again, these are numbers that we're just kind of pulled for an example. It's not probably 100% accurate. But we'll say that, hey, the test we know is going to be positive in 9,900 of them, but again, 99% sensitivity there. The other 90,000 people do not have HIV. Okay, so we'll know that based on the prior prevalence there. This means that the test will incorrectly return a positive result of 1%. So still an incorrect 1% of results, just like we saw in the previous example. But what we're going to see here is we have 900 false positives. And what is that? How did that compare to the previous example? Yeah, it's a lot lower, right? So if you look at this, we're going to see we have 9,900 plus 900. So we're going to have a total of almost 11,000 positive results. But here we're going to find we have 92% of those are going to be true positives versus what was the true positive rate in the last example? Only 9%. So notice how it went from 9% to 92%. By utilizing that information beforehand, by saying, hey, this patient's an IV drug abuser, I know that their risk of having HIV is already higher to begin with. This can help you to make a better conclusions about the new test results that end up coming back. Okay. So again, in this case, if you were to have a positive test result in this kind of sample, if you were dealing with an IV drug abuser, you'd have a 92% chance that HIV would truly be in that sample. So you can be much more confident in that result rather than dealing with a group of people who have very, very low prevalence of HIV to begin with. And so this is actually very interesting because I don't know if you guys read about this, but in Australia, they are looking to put in place a program where people who are on welfare programs, they would actually do random urine drug screens on them. I'm not sure if it's urine, but they would do random drug screens essentially. And if you came back positive for too many drug screens, then they could either kick you off or put you into a treatment program or something like that. And so you can see that depending on what the prior rate is of things like illicit drug abuse in that population is, I don't know what it is for Australia off the top of my head, but you may see that there could be a lot of false positives, there could be false negatives that could lead you to making incorrect conclusions and may jeopardize someone's welfare status or things like that. So this comes up in true life all the time, as you'll see. I'm desperate to make the conclusion or make the connection here with you guys, so that's why you're like, oh, this is why I should care about this. And so this is the goal today. Anyway, so again, when we are looking at the interpretation of a test result, it really is going to depend greatly on that prevalence there. And to reach that correct conclusion, we have to be able to combine our baseline frequency, the kind of prior knowledge that we have, with new data. And so that's very difficult for people to do. And this is why we have things like predictive scores that will help us. So for instance, you guys ever heard of like a CHADS-2 score? Basically gives you cardiovascular risk, cardiovascular death in the future. And it's looking for things like demographic data. It's looking for things like prior disease states. And because if you have a certain set of risk factors, you are more likely to die from a cardiovascular death. And then we can put you into more invasive testing or more invasive treatment, things like that based on these kind of risk factors. So knowing that baseline information is really, really important to help you make better decisions and to be able to interpret results more correctly. Okay, and so there's also this case of multiple comparisons. Everyone heard this problem before with studies? So when we're looking at a study, in order to find statistical significance, basically what we're looking for is a result. You guys ever heard of p-values before? What's a p-value? Yeah, it's basically telling us, so say for instance, I was looking at, and this is not as applicable because we have a higher proportion of, say, male students in the PA class as we used to. I think when I first started here, we maybe had like 3 or 4 males in the entire class. And so if you were to look at it, say, the whole group here, if you were to say, hey, what's the proportion of male PA students, could you apply that to every single other PA program in the country, right? So are you guys representative of that or not? And you could do things like a p-value. You could do a statistical test to determine, are you guys statistically significantly different than the rest of the PA programs in the US, or are you guys truly representative of the entire population, right? And so we can use things like p-values that can tell us that. And usually what we're shooting for is a p-value less than 0.05, right? So there's a 5% chance that your makeup of males versus females is completely random, right? And so and we'll talk about this more in detail, but that's one of the things we're kind of looking for is a p-value less than 0.05. That still means there's a 1 in 20 chance that result is wrong, right? Which is, again, not super great, but that's, again, what the medical literature is kind of our standard is, what we're going for. The more comparisons I start to look at, so then instead of looking at male versus female, I'm going to look at, say, brown hair versus blonde hair. I'm going to start to look at, birth year. I'm going to start to look at different things like that. The more comparisons you make, the more likely you are to find a true result out of just random chance, right? And so multiple comparisons is a big problem that you're going to run into because people will data mine their information to try to find something that is statistically significant so they can report on that. Because if you imagine if you're trying to publish a research article, what is more likely to get published, a negative result or a positive result? Positive. People want to see positive stuff, right? People want to see new, innovative literature. They don't want to see the same old thing being done again and again. And this is a huge problem with medical literature, is this kind of data torture that happens based on multiple comparisons. This is one problem at least. So say, for instance, we have a health statistic for 10 million residents for Ontario, Canada, so a very large N, right? That's a very large sample size that we can pull a lot of data from. They were mined here, right? So mined basically going through and just finding lots of different information about them. And so they examined 223 different reasons for hospital admission. Okay, so they looked at all these people being admitted, say what was their reason for that. And they tested to see whether or not it occurred more often in people born under a particular astrological sign. So what do you think? Do you think astrological sign has anything to do with the reason why you're admitted to the hospital? Who said yes? You think so? Yep. So if I'm a Scorpio, I'm more likely to go in for pancreatitis. Versus I'm a Gemini, I might go in for So who knows, right? So I think most people probably say that there's probably no link there, right? And so they looked to see that they actually found 72 diseases occurred statistically significantly more frequently in one sign than all the others put together. And so the question is that actually true, or is that just something we found by random chance? And so again, you always have that risk that when you find something that is statistically significant, it is still just due to random chance, okay? And again, oftentimes it's a 1 in 20 chance that we'll see as we move forward. So again, is there a true relationship here? Probably not, I guess, depending on your background and your preferences, you may think so. That is totally okay. I would probably go continuing to think that's probably not a true link there. So again, if you're looking at this, if the test was done to warn about the difficulties, and basically they did this to kind of warn people about interpreting all these different results. And when you do these multiple comparisons, you look at all these things. And again, in this case, there's how many astrological signs? There's 12, right? So if you did 223 different types of admissions times 12, you have 2,676 distinct comparisons, right? So the chances of you finding something that is significant is actually pretty good when you're looking for a result. There's at least you have basically a 1 in 20 chance of finding something that is truly significant. We'll talk about why that 5% is what we use later on in the class, but just realize that just by chance alone, we end up getting 134 significant associations. You would expect just to see that based on that 5% chance. What they end up finding is even more than that, right? I'm sorry, they only found 72 significant associations. So it's actually less than what you would expect to see. But again, they found a lot of significant associations that probably don't really have any clinical relevance to you. Because again, when the patient comes into the ER, are you going to ask them what their sign is? Maybe you're really trying to get their phone number or something like that for data afterwards. But typically, you're not going to ask them what their astrological sign is because it really doesn't have anything. It's not really germane to your questions of why are they in the hospital. Okay. Another thing we tend to do is try to ignore alternative explanations. So for instance, if we're looking at a study of acupuncture for osteoarthritis. So, and again, I'm sure you guys will learn some of this in your complementary alternative medicine course. So you'll learn a little bit about acupuncture and Tai Chi and all kinds of different things. But basically what these patients were doing is they were asked to rate their arthritis pain before and after treatment with acupuncture. What they found was pain decreases in most patients, and when they did the calculations, they found that consistent findings are exceedingly unlikely to happen just by chance alone. So they did find a statistically significant difference here for patients who reported their pain scores before and after. So the question is the acupuncture, did it actually work, right? So some people would jump to the conclusion, so yes, it probably did work, but there could be alternative reasons for this. So for instance, is there a placebo effect, right? I can give a lot of people just sugar pills and they will have good positive effects on their depression, on their hypertension. Not to short my profession out by any means, but placebo effect is huge, right? It has a very huge effect on a lot of people. And so that's one of the things you are concerned about as being a reason for finding results like this. Or the patient wants to be polite. They're like, hey, we just stuck a bunch of needles in you. I have to pull all these out. How do you feel? Like, I feel better. Please take them all out. You have other changes in treatment. Maybe they had something like, they started taking aspirin or they're exercising more, they have supplements. For instance, they could have, subjects with worsening pain. Maybe they were excluded. Maybe you excluded patients who you did not want, that you were unlikely to see good results from your study to begin with. And then what you can see is that pain from osteoarthritis can vary from day to day. And so we have this term called regression to the mean. We'll talk about a little bit more detail in a little bit here, but it's one of those things where people tend to regress back to the mean over time. People will vacillate some degree. Some day their pain scale will be a 6, some day it'll be a 4, and sometimes it'll be a 5, right? So it just depends on those patients. So the point being here is that we need to do things in our studies to make sure that we are eliminating risk of these different things here. So for instance, when I have, you guys ever heard of a double-blinded trial? What does that mean? Yeah, so this is something where the patients don't know what they're receiving. They don't understand what they don't know what treatment they're receiving, and the researchers also do not know. This helps to eliminate things like that placebo effect, right? So that's why you see placebo-controlled trials where patients will get either no drug or they will get the study drug, and they'll see that way that if there is any placebo effect, you'll be able to pick that up in those patients that were just receiving placebo. That's a very important step that we can do to eliminate those kind of things. You know, looking at your inclusion and exclusion criteria can be very important to look at to make sure that the results you're seeing are applicable back to your patient. That can be another big thing to be looking at. So this is why you need to look at the way the study was done instead of just looking at an abstract and saying, hey, the conclusions say this drug works great, or this surgery works great, or this therapy is awesome. You need to look at to say, like, well, how did they figure that out? You know, what were the patients they included? What was their methods? How did they control for things like this? Again, we're fooled by that regression to the mean, and so we're going to show you a picture just a little bit of simulates several different blood pressures. And again, all values were randomly chosen in the same manner. So all these values are actually random when you look at them. But then they divided the graph into 2 columns, basically a before and an after treatment, right? Again, this is all simulated. And then the values are randomly assigned without regard to the label. So again, we're just assigning these values as a before and after with really no thought to it. And again, in real data, we'd actually conclude there's no evidence that treatment had any effect on the outcome. We'll see why that is in the next. So say, for instance, we have this information here. We have blood pressure here on the y-axis. We have the before and after treatment. And these, again, all these values are completely random, okay? Now, if you were to divide things out, and if you were to look here, these values that were, say, higher and then moved lower, or started lower and then went higher, you can see here that the data tends to all kind of go right back to this mean, where there's actually, it looks like there's no difference here, okay? So again, people tend to regress back to their means, and when we're looking at these studies, we want to see if there is any statistically significant difference here to make sure that they are not just regressing back to that mean. We want to find, if we see a difference, we want to make sure that's actually true and not just due to random chance. So again, we'll go into much more detail on this in subsequent lectures. Okay. So again, when you select an individual, because some measurement is particularly high, you may find that measurements will be lower later. So imagine if you were like, say, put on your white coat that you'll get at the end of the year, and you go and measure someone's blood pressure. What might you imagine it be, higher or lower than normal? It could be higher, right? Because people have white coat hypertension, right? They get apprehensive when they see healthcare providers evaluating them. Versus if you were to go back later and say, no, I have a white coat on, or say have someone else go and do their blood pressure, might come back lower, right? So you need to be able to look at these kind of extreme results to determine, is it just due to random chance, or is that patient's blood pressure truly that high? And those are some of the things we're going to be looking at there. And so again, when you select these individuals, and this is why we like to use large number of people, so that way the people of extreme values, either low or high, kind of tend to cancel each other out. So that way we can truly see if there is any actual difference there with whatever intervention we're doing or whatever type of thing we're, outcome we're looking at. So again, this regression to the mean, this phenomenon, again, it can seem, if values are extreme on the initial measurements, they may cancel each other out on the subsequent measurements. People tend to cancel each other out in a lot of cases when you're looking at a large number in a sample, high values and low values. So, one example I'll use in the next lecture coming up that I recorded is if, you were measuring average temperature of people and you were to accidentally pull people who, a high proportion of people had hypothyroidism, what do you think their values would skew to? Lower or higher body temperatures? Typically lower, yeah. So hypothyroidism, you're going to think of lower body temperatures, and so you would end up skewing your data one way versus say too high. But if you did a very representative sample, if you pulled kind of at random from the population that you're interested in, and you had people that were hypo and hyperthyroidism, they tend to cancel each other out and kind of regress back to that mean. That's one of those things we're going to be looking for there. And so just be aware that people can do that, and that's why we're going to look at things like we'll have paired and unpaired tests where we can look at the same individual being measured multiple times, or we'll look at individuals only being measured one time, and that'll be important in some of the tests that we'll decide to do. Okay, so let's do a 10-minute break. We'll come back and then finish up this section, and then I'll let you guys go. So what are some obstacles that we have to learning statistics? Why is this something that we dread, probably either on par or more so than pharmacology? Why is that? It's boring. It's kind of boring a little bit. I'll agree to that. A lot of people have fear of math, right? People think, hey, math is hard. I don't want to have to look at that stuff. It's just a ton of numbers. We're going to see that the math isn't super important for us to know how to do it. It is important to know how these different factors in the study will go into determining the math, which we'll look at. We'll also there's a lot of confusing terminology. So we're going to see that when we talk about terms like significant, normal, things like that, these don't apply in the same sense as we would see with just normal day-to-day conversation, right? So we're going to see these have a very specific meaning to them in the statistical sense. Again, very abstract kind of thinking that we're having to perform here, trying to kind of jump to these kind of conclusions. And then again, we're dealing with probability, not certainty. So as I mentioned before, if a patient comes and asks me, hey, how likely is this drug to, is this drug going to work for me? I'll say it's likely to work for you. It is very likely that a lot of people I have treated with this drug have done very well with it. There's no way I'm going to ever say, yes, absolutely 100% this drug's going to work for you, because guess what? They're going to be the one person it doesn't work for, right? Because we're dealing with probabilities, and not everyone's going to be the same. Not everyone's going to react to the same treatment, to the same therapy. Everyone's a little bit different, right? So all your patients are going to be a little bit like snowflakes, but in general, because most people regress back to the mean, most of them aren't, right? Most of them, that's why you can deal with these kind of probabilities and say, hey, you're probably going to do really well with this this course of amoxicillin for acute otitis media, versus saying like, well, I have no idea if it's going to work or not. I have guidelines that tell me that yes, chances are it's probably going to work for you, right? Okay, so that fear of math, again, you can learn to, so if you think about it, like, if you get a test result back for, say, like a CBC, do you yourself know how to run a CBC? Do you know, like, all the reagents they use to determine what the white count, do you need to know that stuff? Nah, you don't really need to know, right? So we don't need to know necessarily how we're coming up with all these calculations. We kind of take these journals at face value when you're seeing these results. Again, as someone who has published research data before, it's a little scary how much people just kind of intrinsically trust your stuff. Even if you're going to a peer-reviewed journal, and what do you guys think a peer-reviewed journal is? Journal that's reviewed by your peers, right? So essentially, if I'm so for instance, one of my articles that I published was about coral snake bites, and so clinical toxicology is the journal that we publish to, and so I submitted my journal to there, and guess who gets reviewed by? Peers in toxicology. So there's other toxicologists who will review that data. They will look at my study results. They'll look at my conclusions to make sure, one, was the test performed, were all the research done to appropriate methods, or did the results that I, do my conclusions, are they backed up by the results that I came to? So you assume that when something goes to a peer-reviewed journal, that it comes out published, and you read it, you say, hey, this must be the holy gospel. A lot of cases may not be the case, especially if you're dealing with more kind of journals of some ill repute. There are some places that you can get published just by giving them a certain amount of money in a lot of cases. Some of these are not peer-reviewed. So again, not every journal is the same as JAMA or Nature or things like that. So just be aware of that sort of thing. And then again, so going back to our point here is that you don't need to know how the math works necessarily, but you'd be able to interpret when they come up with a p-value or they come up with an odds ratio, being able to look at that and say, like, okay, well, that appears to be significant based on the stuff that I know. I don't know necessarily what math went into coming up with that odds ratio, but I can at least interpret that value, similar to how you can interpret urine drug screen without knowing how they specifically tested the urine, right? Okay, so a lot of confusing terminology here. So again, we're going to learn this kind of unique vocabulary. You guys are already learning a second language in pharmacology, but we'll have some unique uses for words here as well. So again, things like significant, things like error. Like to you, what does an error mean? Something's wrong, right? And what does it mean in statistics? Anyone know? You can just refer back to variability in the data, right? Just kind of natural variance that occurs. So if I looked at all of you, if I said a standard body temperature for a human being is say 37 degrees centigrade, is everyone in this room going to be 37 degrees on the nose? No, there's going to be some variation there, right? And so we can talk about error that occurs due to variability in the data. So we're going to find there's specific amount of, we can kind of shift our mind a little bit when we get to that statistics kind of mindset to be able to reevaluate some of these words. We'll talk about things like confidence. We'll talk about power. Again, not going to be the same kind of confidence and power you're probably used to dealing with, or that you're used to seeing in some of your professors. Just kidding, just joking there. Anyway, so again, we'll learn some of the unique terms and kind of what this means for us in the statistical sense. Okay, again, this abstract thinking, our goal of statistics is to be able to analyze the data that we see based on a sample that we're looking at and then make conclusions. This is a kind of a very concrete kind of thing. We say, hey, I looked at these 60 patients, they showed this to me, this is my results, okay? But the logic of that, the statistics is not really, it's going to be more abstract. It's not very concrete. And so you need to understand that even though I have this sample that tells me this very exact kind of results that I have here, being able to apply that back to a population, being able to apply that to my patient that I'm dealing with, say in the ER, in the clinic, becomes much more abstract, right? It becomes much more about understanding things like the population that was studied in the first case, looking at probability distributions, and also what the null hypothesis is. You guys know what a null hypothesis is?
The opposite of your hypothesis.
Opposite of the hypothesis. Okay, so for instance, if I were to say I was doing say a gender study in PA students. If I was to say, my hypothesis is that PA, based on my observations here, that PA classes incoming are predominantly female based, right? What would the null hypothesis be? There's no difference, right? There could be a 50-50 split between males and females, right? So that'd be my null hypothesis. And so we'll talk about that as being something that means there's no real actual difference between the groups that I'm looking at, or between my sample and the population. So we'll kind of get into some more concrete examples of that. I probably shouldn't be so gender normative in 2017, but again, I just kind of fall back to my prejudices, unfortunately. So again, I know there are other genders that are out there, but we'll just go with male, female for right now for our purposes. I'm going to delete this slide out of my thing so I can't be like called into court later on or anything like that. That would be bad. Okay, that's a problem with like leaving these videos on YouTube, is that they can be called up later on. They can be like, hey, you're totally wrong there. Like, crap, you're right. Anyway, so we'll talk about probability and not certainty. So I mentioned you never want to be 100% in saying that absolutely this therapy is going to be the best thing for you, because when it doesn't work out, your patients can come back and say, hey, you said this was going to work, and then it didn't, right? So that's why we're saying that we talk with certainty, with probabilities, not with certainty, and saying, hey, based on what I know, based on the research that's out there, there's say a 95% chance that you're going to have a good success with this surgery. There is a 3% chance you're going to have one of these complications, whatever it happens to be. But we talk about these probabilities, and oftentimes the lay people, they don't understand what that means. Like they just hear, they want to kind of revert back to those kind of concrete things, saying, hey, the provider said that this is going to work, even though that's not really what you said. But we need to make sure that we are being very specific with our language, so that way we don't get ourselves into trouble. So again, statistics just means you never have to say you're absolutely certain. You say, well, probably it's gonna be like this. It's a lot easier to kind of back out of saying something when you can say, well, it was probably this, without having to say absolutely this is the right thing, right? Okay, so one of the things we're going to look at is kind of applying this information that we're getting from a sample and applying it back to a population, because this is one of the primary things we're going to see in the medical literature. So again, looking at these statistical calculations, we're going to talk about generalizing information from a sample that we collect data from and applying it back to a population. And so the terms here are important to understand, make sure we're kind of using these appropriately when kind of referring back to statistics. And so there's a couple of different contexts we'll talk about this. So in terms of things like quality control, we'll use an example of political polls, clinical studies, and then lab experiments, and how we can apply the term sample and the population in cases. Since we're looking at something like quality control, you'll find that sample and population probably make a lot of sense in this context. So, for example, if I was had a big factory and I was producing say widgets, and I wanted to determine like, hey, are all these widgets being produced according to spec? Are they going to be working appropriately? What's the best way to do that? Do I test every single one that's being produced? No. What do? I sample it, right? So I take a small subset of that, I test those out, make sure they're working appropriately, and then I say that, well, these all worked, so I should be able to generalize back and say that all of them work, right? So is that always going to be the case? Right, because there could be variances, there could be something else that happens there. So again, you can never 100% say that, yes, this is 100% generalizable, but probably, based on our results, based on the statistics, it is most likely that these widgets are going to be, in this whole batch, are going to be fine, right? So that's one of the ways we can use that in terms of like, quality control. For things like political polls, right? So how do we determine kind of what the feel for, or when we were looking at say like who's going to win the election, right? This is probably more pertinent last year. But if you're saying like who's going to win, Donald Trump or Hillary Clinton, we did polls, and what did the polls kind of show us? Does anyone remember? Was anyone kind of following that at all? A bunch of garbage, yeah. Well, yeah, definitely. Right, so a lot of the polls, and a lot of people are very surprised at the outcome of the presidential election, right? So for better or for worse, the people were very, very surprised, because based on the polling, it appeared that different results were going to come about from this, right? And so when you poll people, do you poll every single person in the U.S. or every single person that's going to vote? No, you have a sample, right? So you're going to be sampling people, and then if you imagine, there can be some biases there, right? So bias is going to be a very particular term we're going to talk about in statistics. What do you think bias is? Yeah, something that's going to predispose our results towards one skew or another. So, for instance, if I were to say do a poll to say like, who are you going to vote for, say in the 2018, for senator, if I did that in a specific, say, really kind of high income, affluent neighborhood, it might skew my results one way versus if I did it, say, in the inner city and say a more kind of low socioeconomic status sort of area, right? So that can be very, very important. And like, who is the sample, right? And is this going to be applicable back to my actual results that I care about? In some cases, you may find that's why they always say like, certain types of polling, certain companies will skew more towards Republican, some will skew more towards Democratic based on kind of who they are actually looking at in those cases, right? So there's another example where a sample may or may not be really appropriate to apply back to the whole general population. And in clinical studies, this is the one we're going to be primarily talking about here. So again, we will typically look at a sample of patients that we're going to sample from at random, right? Because again, we want to make sure we try to eliminate all bias whenever possible. But we're going to be sampling that from a larger population. And so when I say population, who am I referring to? Do I refer to everyone in the U.S.? Everyone in the world. Yeah, so I need to define who my population is going to be. So if I'm looking at, say, for instance, I'm testing a new diabetic medication, right? Do I test it for people who don't have diabetes? Do I test it in them? No, right? I mean, we'll do that in some of our early phase 1 trials and things like that. But if I'm testing to see if drug A versus drug B is better, what you're going to find is that we're going to be looking at just strictly diabetic patients because that's our population that we care about. I don't care about how well this diabetic drug works in non-diabetic people. That's not really interesting to me for these research purposes. So you need to define who your population is and make sure that the sample you're looking at is generalizable to that, right? So if I'm looking at, say, for instance, if I'm looking at a drug, and going back to our diabetes example, and I'm using it to say, hey, let's look at patients with diabetes who's, you guys are familiar with A1C? Oh, what was that? Yeah, so it's basically an average measure of your glucose over the past 3 months by looking at the hemoglobin. And basically, if I only looked at patients whose glycosylated hemoglobin, say it was 11, right? That would obviously be skewing more towards people who had very high blood sugars versus people who may have very good control of their diabetes already. And so that can bias my results to say, like, hey, well, these people were uncontrolled to begin with. Now look how good this drug is, right? So you have to look at things like that to see, like, is the sample you're looking at, is that generalizable back to that population? So generalizability is a very important term we'll come across again to make sure that the data we're looking at, if it actually applies back to our population that we care about. Because again, when we're looking at that population, we really just care about our single patient that we're dealing with. So we're going to be getting information from the sample, applying it back to the population, and then we're taking that and making inferences about our single patient there and how well they're going to do with a drug therapy or surgery or something like that. Okay. Again, there's room for disagreement about that precise definition, so it's really important that when you're reading the literature, they disclose specifically who their population is going to be. Who are they looking at? For instance, when I was dealing with coral snake research, right, we're looking through all the coral snake bites that had happened from like 85 up through, I think it was like 2012 at the time or something like that. Obviously, I did not look at people who were bit by rattlesnakes, because that really wasn't germane to my discussions there. So I was really only looking at that population that were people bit by coral snakes. That's what I care about. So they need to make sure that you really disclose who the population is intended to be and make sure that sample is representative of that. And then in laboratory experiments, this one's not going to be super useful to our purposes, and we're not going to talk about it too much. But for instance, if you're looking at laboratory experiments and making sure that like lab results are being done appropriately, typically what you can do is having things like specific data that comes about as your sample. Populations aren't going to be really super useful in this kind of context here. But for instance, you can say like, hey, you'll see this with a lot of like quality control for certain lab tests where you actually have to do, say for instance, you have like a point of care glucose test. Right, you want to make sure that when you measure glucose from your patient that it's accurate, and so you have to do test standards beforehand to make sure that it's calibrated correctly and all of that. So you can kind of apply the sample population example there as well. So what statistical calculations cannot do? In theory, if we were going to apply, some of the analysis would be applied to this kind of simple experiment. So again, we would basically go through and we define a population that we're interested in. So if I wanted to say I do an experiment on all PA students, I might say that, okay, I'm going to look at all PA students in the U.S. Okay, then I'm going to randomly select a sample of subjects to study. And so if I picked you all in this room, would that be randomly selecting students? No, right? And so that could introduce bias potentially because it may skew towards students who want wanted to stay in Florida, or it may skew towards students who had a specific background versus, if I did a sample out in, say, California, or if I did it in North Carolina or something like that. So again, you can see where bias can already start creeping in, and a lot of times we'll refer to that sort of thing as a convenience sample, where it's like, hey, these are the people I had available to me. This is what I'm going to be looking at, and so that sort of thing is again something you want to disclose and make sure that the researchers disclose in their documentation. So, and again, I would say us randomly select half the subject to receive one treatment, and the other half another treatment. Let's say with our what do we call this product here that has like 97,000% B12?
Zip Fizz.
Zip Fizz. I'm going to give 32 of you Zip Fizz and 32 of you just straight water, and we're going to look to see like which students did better on their test, who actually had more energy. Secondary, we're also going to look at urine composition to make sure to see how fluorescent it is. See if we can use it maybe for like I don't know, glow sticks or something like that, right? So basically what we're going to do is measure that single variable. Sometimes you have multiple outcomes that you can be looking at, but we say, let's look at test results and see how well you guys do on pharmacology tests if you did, say, a shot of the Zip Fizz before the test versus just a shot of water, okay? So basically what I'll do is then I'll have this data. I'll be able to measure that from the sample. So I'll say take the test results. I'll be able to use some statistical techniques. I'll say look at the test averages between my control group, the people who did not have an intervention, the people who had water versus the people who drank the Zip Fizz, and I can do a statistical test to see, hey, is there a real difference here, or are the results completely random? The product had no effect whatsoever, right? So that would be kind of an example of what I could do, and then I can apply that back and say, hey, well, in this sample of PA students, I found that Zip Fizz is completely ineffective, and you could report, somewhat generalize that back to all PA students and say, hey, this product's probably not good. Let's not go ahead and endorse this. Or you may find it's totally useful, right? It's important to go in with the clear head and make sure you're not going to make any. Your researcher bias is a really big thing, so you want to make sure you kind of go in with that open mind and say, hey, well, let's just see what the data actually shows. Okay, so again, we'll see that scientists often encounter problems that kind of limit the validity of their statistical reasoning. So, for instance, if we're going to design a study to test, say, how effective a drug is at treating patients with HIV, like how would I design that study? What are some things I could look at in a patient with HIV to determine how effective treatment is? Okay, so I could look at CD4 count. That could be one thing that can kind of help me. What's something else I'm kind of more interested in? Viral load is another thing I could look at. So opportunistic infections they may develop. What about if I want to see how long they live for? Right, may want to look at outcome like mortality. That can be again is another really important thing that people are going to look at to say like, well, if I do this treatment versus this treatment, like who lives longer? Right, that's a very important thing. I'm sure most of your patients want to live as long as they can in a lot of cases, and so you're going to find that that's another question they have. Like, hey, can I use this treatment to help extend my life? Am I more likely to live longer instead of dying of a heart attack or dying from an opportunistic infection due to HIV? So again, when we're doing these kind of studies, ideally we like to look at all patients who are infected with HIV. Obviously, that's going to be impossible, and you're never going to get a true sense of what the actual population values are going to be because you can't sample everyone, right? And again, in this case, if we want to know whether a drug increases lifespan, how long is that going to take us? A long time, right? Especially nowadays, patients with HIV are starting to live much, much longer. You may have to wait decades before you really find any of these results. So a lot of times, those kind of studies are kind of impractical, and so we rely on kind of surrogate markers to help us out with that. So it's where things like viral load, CD4 count, other opportunistic infections popping up. Like those are other things we can measure more immediately and give us a better idea of how well a treatment might work. So again, realistically, we're going to end up seeing that you're going to limit your population that will be able to have access to your study. So for instance, if I was looking at HIV patients aged say 20 to 40 who live in San Francisco who come to a university clinic, right? So in these cases, I may say, well, let me set my exclusion criteria. Who are the people I do not want in my study? Let's say that patients that are too sick. So again, if they already come in, say they have Kaposi sarcoma, or if they already have PCP pneumonia or something like that, they're too sick. I don't want to include them in the study because they're going to skew my data towards looking like the treatment's no good. Okay, or they can skew one way or the other. If they're on other experimental drugs, that could have undisclosed bias towards a patient either doing well or not. Or they're unable to cooperate with the experimental protocol. That's really an important thing, is whether or not people actually are adherent to the treatment regimens you're going to see here. In some cases that can be difficult. Sometimes there's things we'll do to try to make sure patients are adherent, but that is another concern we had there. And so in this case, instead of looking at something like lifespan, which would take decades in order to determine, we can look at things like CD4 count, because we have previous studies that tell us that if a patient has a higher CD4 count, they typically live longer, right? Because they have a more their immune system is working better, they should be able to fight off infections more easily. Okay, so at that point, then we can extrapolate findings to a wider population. So even though we're only looking at people, say 20 to 40 living in San Francisco, we can apply that out to other patients with HIV to say, hey, this probably works. And it's your job as a clinician to determine, hey, is that appropriate, right? So for instance, if I was working over, say, in Africa, is information on HIV trials done in San Francisco applicable to Africa? I don't know if anyone's like well versed in HIV. It's really not, because there's actually different strains of the virus, and so HIV-1 versus HIV-2, you're going to have different distributions of it in different parts of the world. And so you may say, hey, that doesn't have any applicability to my African patients or patients in Africa, versus if I was, say, in Florida, I can probably say, well, San Francisco HIV might be a little different than Florida HIV, but chances are it's well enough, close enough that I can maybe try this therapy for my patients if it appears to be effective. Okay, so you have to make that decision whether those patients that we're looking at are generalizable back to your patient you're dealing with. Okay, so again, maybe useful to do something we call a meta-analysis. Anyone know what a meta-analysis is? Yeah. So you take a bunch of different studies, you put them all together to try to see, like, hey, what is to try to answer kind of a general question, right? Has anyone heard of a Cochrane review or the Cochrane database? They're something you'll run into when you start to like do research on specific disease states or therapies. But they are an organization that pulls together a ton of different studies to answer different questions. So, for instance, what is the best treatment for hypertension? They may pull together a lot of different studies and say, hey, based on these different studies, they do a meta-analysis and say, hey, based on this, we think this is the right answer, and this is maybe a backup answer or something like that. So you'll find those are very, very useful for helping you to determine treatment for your patients. But anyway, so you may do something like a meta-analysis to look at different measures for effectiveness. So if you see like delayed reduction in CD4 count, that can be a very important outcome. They keep their CD4 count higher for longer, prolongation of life, increased quality of life, reduction in medical costs. So these are all other kind of secondary outcomes you could also be looking at in these type of studies. So then these statistical calculations, they help kind of in overcoming some of the following problems. So again, the population we really care about is more diverse than the population being sampled. So again, one of the things we can do is to see how close we think our sample that we're looking at is generalizable back to that population. And so some of the things we can do is look at some of their baseline characteristics to determine, hey, are these patients skewing younger or older than what the general HIV population is? Or are they skewing sicker or more well? So you can look at different baseline statistics to see how close they are to the actual population you're interested in. You can see that subjects, if they're not randomly sampled from a larger patient population, that can skew your results for sure. So for instance, if you're only looking at patients with HIV who are showing up at a university clinic, who does that potentially exclude? Who might you not include in your study? Maybe the elderly patients, homeless patients are a big one, right? So unless you're capturing a lot of homeless patients who don't have very good access to treatment, you may not be able to see, what type of effects you would have on their HIV, right? So you have to think about, who, and again, statistics can't really help you with that, right? So this is why these are things you have to include in the methodology to say, hey, we understand this is a limitation. We understand we did not capture this group of patients, but here's why we think this, these results are still valid. If we have a measure as variable as a proxy or a surrogate for another one, so for instance, if CD4 count didn't really correlate back to life expectancy very well, that's not a very good test result for us to actually look at. So you need to make sure that those things correlate very well together, and usually use kind of previous literature to kind of help you with that sort of thing. If you have results or measurements that are being made or recorded incorrectly, so for instance, when I talk about the body temperature example in the next lecture coming up, for instance, if you're testing all your patients with, say, rectal thermometers to see what their core temperature is, and then some people, one researcher comes in and just does oral temperatures, that can skew your results, right? So you need to make sure you're kind of measuring things appropriately, measuring things consistently. And then oftentimes see that clinical conclusions require looking at multiple outcomes. Again, the more comparisons you make, the more likely you are to find results just by random chance, significant results. And so we're going to talk about some ways we can combat that. There's some tests you can do to limit the chances you find comparisons when they're not really there. Again, statistical conclusions are always going to be vague to some degree. Again, we're trying to make general conclusions about a very specific sample and apply that back to a population. And so again, we talk about generalizability, and it's never going to be 100%. You can't always say that these 60 patients that I looked at is going to be representative of the million people who have the disease I'm interested in, right? So that's why we use things like probably, most likely, almost certainly. We never said, yes, this is absolutely going to be the case, because you can have another study that comes along and completely refutes you, right? So that's why you got to be very careful with your language and make sure that if you have studies that are being very, very concrete and saying like, yes, this is absolutely the way to do it, chances are that's not a very good study, right? So you need to make sure the language is appropriate. And again, be wary for conclusions that seem 100% definitive, as I just mentioned, and be wary of the term statistically significant. We'll talk about that a lot and what that means, and it's important. Just because something is statistically significant, right? So, for instance, if I were to say, I were to measure, or I guess let's go back to our example. I was able to give half you guys zip fizz and half you guys not zip fizz. We did our test results and say the average on the farm exam. I'm going to say you guys did really, really well in studying, and the average was 97 for people who just took water, and it was 98 for people who took zip fizz. Statistically significantly different. Do you actually care about that 1 point? Not really, right? So whether or not the results are clinically significant, or they're actually, they actually make a difference to you, that's important, right? So you need to look at those results where you can see very, very tiny differences that are statistically significant. They don't actually mean the hill beans to you, right? If a drug drops a patient's blood pressure 5 points versus 6 points, I don't really care about that, right? So those are other conclusions you have to kind of look at. Okay, so we'll talk about models and parameters. So what do you think a model is? So that's someone who walks down the catwalk. Or what I put together in my basement. Just kidding, I'll do that. I don't have a basement, we're in Florida. These Legos. Huh? So a model is something we can use. So basically what we can do is we can take a sample, we can take a group of people, and we can look at something and say, okay, well, based on these type of outcomes, and so there's a really good example, the Framingham study, and that's where our CHADS2 risk score comes from when we're looking at cardiovascular risk of death. And so what they do is basically they have this town where they're looking at all these different people. They look at different kind of baseline demographic factors. They look at things like what type of drug treatment did they receive, what type of disease states do they have, and they take all this information and they make a model out of it. And they say, okay, well, people who had diabetes were more at risk for cardiovascular death by this many percentage points. People who smoked were this much more at risk. And they can take that model, and then you say, okay, well, if you have these type of demographics, you are going to be at this much risk for having cardiovascular bad outcomes. And then you apply that back to a population. Okay, so those are an example of a model you might see being used. It basically involves a lot of math to try to fit the data that you have, fit a line to that you can apply back to a population. So we'll have a whole section on that later on that we'll talk about. But just be aware that when we're looking at these things, we're going to be looking at kind of general description of what the model's showing us, and then we'll be looking at these parameters. So for instance, if I was giving you a drug that is meant to be an antihypertensive, or if we look at the concentration in the blood as it decreases, we're going to be looking at half-life as our parameter here. Or we're going to be looking at cardiovascular outcome, or things like do they need cardiac catheterization, or things like that. So again, you're going to be fitting these parameters into the model to come up with something that can be predictive back to a whole population. And then looking at probability versus statistics. So again, these two terms are going to be pretty distinct from one another, as we'll see. What we'll see is a probability is going to start with kind of a general case. So say we're starting with a model that we already have developed or a population, and this is going to then predict what would happen in many of the samples, right? So say, for instance, if I were to know what the incidence or the prevalence of HIV is in the population beforehand, I could use that information to apply it back to my patient, or I can apply it back to a specific sample. So in general, when you're looking at these probabilities, this is using information that is very general or applying to a population, and I'm going to apply it to something more specific to try to make inferences about that smaller subset, right? Versus when we're dealing with statistics, I'm working with a sample. This is, going back to the zip fizz analogy. We're going to be working with something very specific. I'm going to get these test results. I'm going to look at the data to see if there's any statistical significance there, and then I can apply that back to a larger patient population, right? So again, probability is going from general to more specific, versus statistics are working with something very specific and trying to make that more general. Okay, so that's kind of the general flow of things. Okay, so that's it for the first section. You guys have any questions about this? Have I made this interesting in the least bit? As I mentioned, one of the reviews I had saying for this class last year said that EpiBio is like a bucket of sand that you're being forced to eat. I at least made the first bite look a little appetizing. They didn't reference anything about the subsequent bites. But so Friday, you guys have 3 blocks of this scheduled, right? I think so. So you guys, I know we're going to be very diligent in watching all those videos on Friday. Don't let the number of videos be representative of the number of blocks, right? So I may have shorter videos. I'm going to roughly make it equivalent to our class time would be, right? So if we have 6 hours roughly, or 5 times 6, so 300 minutes roughly worth of videos that you would have. That's kind of a scary number to think. I don't like that number. kind of that's basically what we're going to be equating it to. So I'm going to make sure I'm not going to give you guys extra videos to watch necessarily. I'm trimming down a lot of things from last year to try to make it much more very specific to you guys. Make sure I'm kind of cutting out a lot of the fluff. So I'm kind of doing that in real time as I go through. So the videos will be posted by tomorrow, and it should be roughly 6 hours ish, a little bit less obviously if we do 15 minutes per block. That'll be roughly what we cover. Okay, so it'll be multiple videos, more than 3 likely. Any questions? All right, I will see you guys around.